I want to get back to kind of, we have an abundance of riches. So we have ribociclib and we have palbociclib. So how do we decide? How are we going to make that decision? Kim, you were on one of the Mona Lisa trials. I mean, what's your experience with ribociclib?
Well, my honest answer is the drug that's the easiest for my patient to get and the easiest for me to get for the patient is probably going to be my choice. So things like co-packaging the CDK inhibitor with the AI.
That's pretty slick, actually.
Dosing, you know,
That's slick.
Central pharmacy versus a specialty pharmacy. I mean, these are the things that really make an impact on a practice. And we're all busy practicing physicians, and anything that reduces the confusion, improves compliance, reduces the stress, right? I tell a patient, oh, you got to take these 2 pills, and then they go to the pharmacy and find out it's going to be a 3-week wait, and they have to sit on hold for 2 hours. I mean, it's created a stress in the clinic. So I'm looking for all of the companies that make these to really help us get these very effective drugs to our patients. So that's my honest answer. I mean, obviously, if one of the more studies as they mature, there's a survival advantage, or there's really some absence of toxicity that we saw with other drugs, those will influence my decisions. But right now, I just don't see a huge difference with the data we have across the drugs.
From a mechanism of action and toxicity and efficacy, ribociclib and palbociclib are very similar. There is the issue of cardiac conduction and QTc prolongation with ribociclib, which does require more monitoring, and the rare transaminitis that requires monitoring. Ribociclib is a little easier to dose adjust, though, because it's 600 milligram and it comes in a dose, and it comes in 200 milligram capsules. So, you know, they each have their pros and cons, and I agree with Kim. You know, at the end, different centers, depending on how they're set up, and insurance companies, it's going to really be what makes it easier for the patient. Now, abemaciclib is pharmacologically different, and
which we'll get to in a sec.
We'll discuss that separately.
We'll discuss abemaciclib, but I mean, let me ask. I mean, we have a lot of really good translational biologists sitting at this table. I want to ask you, but before we go back to ribo, this question just came up. Are we believers in this Ki-67 drop? As a surrogate. We're believers in it. We think it's reasonable.
Absolutely. In ER-positive disease, every single study that has been shown to be positive, the Ki-67 is a great marker of an effect. We saw that initially in the initial adjuvant studies with everolimus. We saw this in the combination studies with anti-ER therapies. We're seeing this now with CDK4/6 inhibitors. So I think that's a very important readout. So I'm convinced.
Yep. So that's good for people.
And it's also a good way of triaging negative trials. The gefitinib and arimidex trials that Mitch Dowsett reported did not have a change, and they did not work in the metastatic setting. So sometimes you can use them to predict almost metastatic studies that you should or should not do.
That's really good. That's a very good point. Okay, so basically what I'm hearing from everybody is that, you know, these are similar. It's really going to depend on a lot of maybe potentially non-clinical issues or non-efficacy toxicity issues to make the difference between ribo and palbo at this point in time. And I think those are reasonable things, and I think it's good that we have more options, I think, for patients now. It's always better to have more than one.
And I think it's important to point out, though, that there is going to be a lot more data with each of these agents. Correct. So I think for the general practitioner right now, what we are saying applies to really 3 large randomized, Paloma 2, Paloma 3, and Mona Lisa 2. But there's like 15 Mona Lisa studies with ribo, and I'm sure there's 15 or more with palbociclib. And so, I mean, as an educated provider of these drugs, we'll have to stay on top of all of the studies as they emerge.